remain standing and raise your right hand toward the front. You solemnly swear affirm the testimony you're about to give this board with the truth, the whole truth, and nothing but the truth, so help you God.
I do.
Thank you. Please be seated. Speak directly in the microphone, and please state your name and spell your last name.
Sure. So I'm Dr. Stephen Messner. Who was that first name was?
Spell your last name.
Oh, it's M as in Mary, E, S, S like Sam, N as in Nancy, E, R.
All right, thank you. Ms. Yee?
Thank you. Dr. Messner, where are you employed?
I'm employed at Children's Healthcare of Atlanta.
And what do you do there?
So I'm a child abuse pediatrician.
And what does a child abuse pediatrician do?
Sure. So I'm a pediatrician who specializes in child abuse. So in order to be a pediatrician, I went to medical school. I graduated at the Medical College of Virginia, and then I went into a residency, which is in pediatrics. So that's 3 years of training after medical school. And then and I did that at the University of Florida down in Gainesville. And then following that, I stayed on faculty at the University of Florida, where I saw children in the adolescent clinic as well as in the general pediatrics nursery, the acute clinic, and then about 60% of my time I was seeing children for concerns of child abuse and neglect. And then in 2007, I moved up here to Atlanta, to my current position where I'm with Children's Healthcare of Atlanta. So 100% of my practice is evaluating children for concerns of child abuse and neglect. So I'm board certified in general pediatrics as well as in child abuse pediatrics. There are 361 board certified child abuse pediatricians in the US. There are 5 of us here in the state of Georgia.
And are you licensed to practice in the state of Georgia?
I am, yeah.
And so how long have you been a child abuse pediatrician?
So I got board certified. So the board certification came out in 2009, and it's every other year. So I sat for the boards in 2011. So I've been board certified since 2011. We now have a pediatric fellowship in child abuse pediatrics, and we started that fellowship in 2012. I was the first fellowship director. We've graduated 4 fellows, and we have 2 who are in training right now. So it's a 3-year training program. Let's see. So that's in conjunction with Emory School of Medicine, as well as at Children's Healthcare of Atlanta. So I've been board certified since 2011, but I've been seeing children for concerns of child abuse and neglect prior to the board certification, so since 2004, and 100% of my time since I came up here in 2007.
And besides being a child abuse pediatrician, what other positions do you hold at CHOA?
Sure. So I'm the medical director and the endowed chair for child protection at Children's Healthcare of Atlanta since 2015. So we are part of, so our advocacy center is called the Stephanie V. Plank Center for Safe and Healthy Children. So we're one of the child advocacy centers here in the state of Georgia. Like I mentioned, there's not very many child abuse pediatricians in the state. 4 out of the 5 in the state are at Children's Healthcare of Atlanta. So the 5th one is down in Macon. So we do provide a lot of the medical exams for other child advocacy centers, and we do trainings to other medical providers throughout the state.
And what exactly is your role as a child abuse pediatrician?
Sure. So it's there's multiple roles. We wind up getting involved whenever there's a concern of any type of child maltreatment. So that could be child sexual abuse, child physical abuse, medical child abuse, which is what we prefer to call like Munchausen syndrome by proxy, where some caregiver is manipulating the medical providers to harm the child. So we get involved either if like the child comes to our clinic, which is our advocacy center, they'll come to us either through DFCS, law enforcement, or like a pediatrician, family practice provider who has concerns about some sort of maltreatment. Then they'll refer them to our center. And then we also cover the hospitals. So we have 3 hospitals. Hugh Spalding is the smallest, and we have Scottish Rite, as well as the new Arthur M. Blank Hospital. We used to see children at Eggleston before it closed. So at the hospital, we'll see children if there's a concern of, it's primarily child physical abuse. So if one of the providers say it's a trauma team or neurosurgeon, the hospitalist, if they have concerns about injuries on that child, then they'll ask for a consult from my service. So either myself or one of my colleagues will go and complete a consult. Similar to if there was a child that they had concerns about the heart, then they'll consult the cardiologist to come in and evaluate them. If there's concerns about any form of child maltreatment, then they'll ask for a consult from my team. We do see children at all three of the hospitals, but it's primarily at Arthur M. Blank and at Scottish Rite because they have the PICUs, they have orthopedics, and they have neurosurgery. And so a lot of the children who we evaluate have either broken bones or head trauma, so that's why we see the bulk of the children there.
And in your years of practice as a child abuse pediatrician, how many cases have you evaluated?
It's thousands.
And have all of those children been diagnosed as having been abused?
Oh, no. Actually, I pulled the numbers. So we look back over the past 3 years, so from 2022, 23, and 24. And my team, we reviewed 3,526 cases. And then the teams actually asked us to consult on 1,122 of those, so about a third, 32%. And we made a diagnosis of abuse in 394 of those cases. So that's 11% of that overall 3,500 cases and about 35% of the consults that we got involved in. So it's the minority of cases that we make a diagnosis of abuse in. But we, so it's not the majority of cases.
And as a part of your job, are you able to recognize child abuse versus medical conditions that can look like child abuse?
Sure, so like mimickers or, other medical conditions, absolutely. That's one of the key concepts that we get across to our trainees. So we do a lot of education to medical students, residents, fellows. We have our own fellows who we train, as well as other medical providers throughout the state to know what to look for. What are the telltale signs of abuse versus some other medical condition? We also do trainings, like I've done those sort of mimicker trainings to defects workers, to law enforcement, to attorneys, to judges, not just throughout the state of Georgia, but nationally and internationally.
And do you keep up with medical literature and studies on child abuse?
Yes.
Do you also have continuing medical education regarding the area of child abuse?
Yes, so in order to remain board certified in general pediatrics as well as in any of the subspecialties, it's governed by the American Board of Pediatrics. So you have to do what's called a maintenance of certification. And I'm up to date on all of that, so I'm board certified in both in good standing.
And have you ever had the occasion to testify in court in your capacity as a child abuse pediatrician?
Yes.
How many times?
Over 200 times.
And have you ever been tendered as an expert in the field of child abuse pediatrics?
Yes.
Or at the time, the state would tender Dr. Messner as an expert in child abuse pediatrics?
Any objection?
Your Honor, our objection is to the term child abuse pediatrics. He's obviously qualified as a pediatrician. However, the issue of child abuse is the ultimate issue for the jury to determine. So we object on that basis, but we have no objection to his qualification as an expert in pediatrics.
Anything?
It's the name of this board certification.
Of course, to accept him in that field. Objection over.
Thank you. And Dr. Messner, are you familiar with Emma Hernandez?
I am, yes.
And how do you know Emma Hernandez?
Sure, so I was asked to complete a child abuse consult on her back in June 7th of 2023.
And why was she admitted?
Yeah, so she came in through the emergency room. It was after she had gone to her pediatrician's, and she had gone there with her older sister. Her mom had asked for the pediatrician to also take a look at Emma because she had a concern about the soft spot on her head as well as her leg. And the pediatrician had concerns about her leg, so asked her to come to the hospital. So in the emergency room, she had some x-rays done that showed that there were fractures in that leg, and then she got admitted. By the time I got to complete the consult, which consisted of me meeting with the mother, because she was at the hospital. I had reviewed the documentation that's in our medical records, so it's electronic. It's a system called Epic, so we can pull everything up, and even pull up records from before she was in children's through a function called Care Everywhere, so I was able to see one lab result before her hospitalization. But the mom was in the room. She had already met with DFCS and law enforcement on the day that she was admitted, which was on the 6th of June. And then I did the consult on the 7th of June. And when I did the consult, mom indicated that she spoke Thai, so we had a interpreter on the what's called the Cradicom, just in case mom had any questions, with what I was saying in English. Mom didn't interact with the interpreter at all, but she was on the interpreter was on the Cradicom during the entire time that I was there talking with mom.
Okay, and you said that you spoke with mom, so what information are you getting from her?
Sure, so it's a lot of information. So I asked the mom, about Emma's birth, about any medical conditions that she has, if she had ever had any concerns about her development, what she could answer, those sort of things. I find out the social history, which means who all is living in the home, who cares for Emma, where does she sleep, what position does she sleep in, ask about family history, particularly asking questions about anybody in the family who has propensity to bleed or bruise, like specifically having hemophilia, von Willebrand's disease, anybody have problems with easily fractured bones, joint laxity, so osteogenesis imperfecta, Ehlers-Danlos syndrome. So I ask all of those questions, ask a review of systems, which is, how has Emma been over the past few weeks, any fevers, vomiting, anything that was abnormal, any abnormal bruising. So mom gave me those answers. Then I asked, well, why are you here? Why did you bring Emma, to your pediatrician? And that's called the history of present illness. So the history of, why are you here for this visit? So I got all of that history from mom, then documented that in the medical record after I completed the consult.
Okay, so tell me about what mom specifically told you about the history that you
Sure.
just went over.
Yeah, and I'm just going to look at my consult note to make sure that I'm accurate. So she told me that she had that appointment on the 6th because she was worried about the soft spot in the middle of her head, and she said, and also an ear bruise. And then she said that Emma's older sister, Araya, had the appointment for an ear infection, and she asked them if they could also see Emma, which they did. And then mom backed up and said that the day prior, so on the 5th of June, 2023, she was giving Emma a bath, and she noticed that her right leg was larger than her left. So she asked the pediatrician about this during that visit, and she said that the pediatrician wasn't concerned about Emma's head, but was concerned about the leg. So she asked her to bring her to Children's Healthcare Villain at Scottish Rite. And then I asked her, well, what do you know about Emma's injuries? Because at this point, she had already met with other providers, had met with law enforcement and defects, and she said that her injuries are broken fractures, and then she said that it was of her legs and her ribs. And then she said, last night I heard that the detectives say the finger too. And she indicated to me that that was Detective Cooper from Forsyth County Sheriff's Office. And then I asked her, well, how could this have happened? Did anything happen to Emma? And she said, no, she didn't have any falls or drops. And she specifically said that she would never put her in a position where she could drop. And then I asked, do you co-sleep with Emma? Does anybody sleep with Emma? And she said they didn't, and she's worried about her safety. When I was asking mom about the bruise that she said she saw on the ear, she said she noticed it a week ago when she was breastfeeding Emma, and she thought that maybe it was from feeding her. And she told the dad to make an appointment with the doctor, but then when Emma was seen by the doctor, the bruise had already gone away. And she showed me a picture of this, And I was there with our DFACS liaison, Charity Kemp, and so Charity asked her to text that picture to her, and which she did. And it shows a pretty significant bruise, not on the ear, actually, it's on the scalp.
Transfer States Exhibit 1, is this the photograph you're referring to?
It is, yes. Mhm.
All right, continue.
And then I asked her about any other bruises she had seen, and she said that she saw one on Emma's eyelid, and she thought maybe Emma had scratched herself. And then she said she saw one on her neck and on her torso or trunk. She said that that was maybe from the seatbelt, from the car seat. And she said that those lasted for about 4 days. And she said that she didn't have any pictures of any of those bruises.
And she specifically characterized these as bruises?
That's correct.
All right. Did you ever inquire as to who Emma's caregivers were?
I did, yeah. So Mom said that she's the primary caregiver. The maternal aunt mainly helps out with the older sister, Araya, and the maternal aunt's name is Panyarat Schult. And then Mom said that Dad would help out with feeding Emma during the night for the first 2 months, but now he doesn't participate as much. She said that, she did make this comment about Araya, the 3-year-old sister, if maybe she had caused the injuries because she's an active girl who plays close to Emma. And she says she's sometimes a little bit rough. And I asked her, like, what does she mean by that? And she says when she tries to play with Emma, and then she kind of demonstrated pulling on her hands. The other caregivers, besides the mother, father, she does not go to daycare. Mom stays home with the children. So those are the only ones that she had told me about.
And after, because let me go back to other history. Did the mom ever indicate that there was anything wrong with her pregnancy or that she had any pregnancy complications?
No.
Did she indicate that she had any problems during delivery?
No.
Did she indicate that there was any family history of genetic issues?
No.
Were those questions asked?
Yes, I asked those specifically. So she said that she was either 38 or 39 weeks gestational age, which is term, that she was born by vaginal delivery, no complications, and then was at Northside and Cumming, went home with Mom. And I always ask this question this way because sometimes parents they may not think that something is maybe wrong with the baby. So I always ask, like, did you go home on any medicines or on any monitors? And she said no. So that's why I asked that question that way. And then she follows regularly at Sunshine Pediatrics in Cumming. And then the family history, like I mentioned earlier, I asked those specific questions about bleeding, bruising, bone issues, problems with the connective tissues. My mom indicated no.
I think you also asked a question about co-sleeping.
Correct.
Was there any indication, or did she ever tell you that they co-slept?
No. She said she sleeps in a bassinet on her back, which is the preferred position for a baby.
And what about family history? What did she say about family history?
Oh, that was the questions that I asked about the bleeding, bruising, bones, and connective tissue issues. And she said that there was no family history of that on her side of the family.
Okay, and what about the diet? How is the child fed?
Yeah, so she's currently breastfed exclusively, but for the first 2 months, she was getting formula along with the breast milk. And she was just over 2 months when I saw her.
Now, after speaking to the mom, did you do anything else after that?
Yeah. So I can't recall if I did the physical exam. I think I did the physical exam prior to speaking with Mom. So I examined Emma. So that consisted of a head-to-toe examination of her. I had reviewed all of the imaging studies that were in the computer, as well as all the lab work that had come back. And then I sat down and obtained that history from mom.
Okay, so you did a physical exam of the child,
Correct.
and what, if anything, did you notice?
That she was wearing a long splint on her right leg, so that was already placed due to the fractures. That was really the only significant physical exam finding on my exam.
And you said that you also reviewed labs and, did you say x-rays, also radiographs?
Correct.
And tell me about what you observed with those records.
Sure. So, like I said, with the Care Everywhere, it pulls in old labs. So I saw that there was a sweat chloride test that was done back in April 13th of 2023. That's a test that we do to check for cystic fibrosis, and that was completely normal. And that was done because the newborn screening, which is a screening test, came back abnormal. So the next thing that you would do is the sweat chloride. So this rules out that she has cystic fibrosis. On the, she had trauma labs which were done. So that's standard. When we have children who come in, if they're less than 6 months of age, we will get, and there's any kind of, physical findings of trauma. And in her case, there was the swelling of the leg, so they got the x-rays. Once they saw the fractures of that femur, then that triggered what we call the non-accidental trauma pathway. And that is something that we developed with the emergency room physicians to make sure that all of these children are getting the same workup and that we're not missing any kids. We started that early on in my career at Children's. There was a little baby who I was seeing in consult, and that baby wound up being a fatality. And when I looked back, I saw that that child had come in with a femur fracture and only had x-rays of that leg, didn't get the full skeletal survey, didn't have any other workup, and was discharged from the emergency room. So we started something that we do every Wednesday, which is called trauma rounds, and that's when we review all of these cases with our emergency room physicians, the rest of my team, the social workers from the emergency room. There's a whole host of folks who are on there. And that's to make sure that that's how we develop this non-accidental trauma pathway. It was a result of that. So when Emma came in, it triggered the non-accidental trauma pathway, and so that includes lab studies. So it's a series of labs that are all drawn from blood and one from the urine, looking for other forms of signs of trauma. In her case, she had elevated D-dimers, which is something that we would expect with having fractures, as well as a slightly elevated fibrinogen. The rest of her levels were normal. So there wasn't an indication that there was injury like to the liver or to the pancreas. The urine was normal as well. We did check for her bone health, and that had already come back. Her vitamin D level was in the deficient range, so it was less than 20, but we see that all the time in little babies, especially here in Georgia. The other parts of that test to check for the bone health is to look at, was there a response to having a low vitamin D level? And there wasn't. So the parathyroid hormone was normal, the calcium levels were normal, the magnesium, phosphorus levels, those were all normal. So there wasn't any kind of lab finding that would go along with a problem with the bones. And then we look at the x-rays to see if there's any changes, what we would call like metabolic bone disease, changes on the bones, and there was not. So it's just a low vitamin D level. It is not rickets. It's something that we see very frequently. The other tests that I had access to at the time were a head CT, which thankfully showed that her brain was fine. There was no blood around her brain, but there was some soft tissue swelling, so you could see that in the scalp. we had what's called a skeletal survey. So that's x-rays of all the bones in the body. And that was significant for a number of fractures. What we saw was on the chest that there were healing fractures of the left ribs, 3, 4, 6, and possibly 8. And the 3, 4, and 6 were on the side. The 8th one was on the front. There were also fractures that we call classic metaphyseal lesions. And those are, rib fractures and classic metaphyseal lesions are highly specific for child abuse in a child less than 1 year of age in the absence of any kind of trauma history. It's because the way that you get those fractures, you get the rib fractures from a squeezing force about the chest. The way you get the corner fractures or the classic metaphyseal lesions is from either the arms and legs like flailing about, and you get the forces concentrated at those joints. So most commonly we see this about the knee. So at what we say the distal femur, which is like the knee end of the thigh bone, or the proximal tibia, which is the knee end of the shin bone. So most common places that we see those kind of fractures. And then up at the shoulder and the humerus. And on Emma, we saw that she had classic metaphyseal lesions of the right femur up at the hip, the right femur down at the knee, the right tibia up at the knee, and then in the foot there was a change to the bone on the inner sole side, so like on the big toe side of the foot bone called the metatarsal. There was a change there. So based on what I saw on those x-rays, what the mother told me about this past history of this bruise, I saw the picture of the bruise. She told me about other bruises, and we had checked for any kind of bleeding disorders. We did what's called a DIC screen. That's where the D-dimers came back elevated. Everything else was fine on that. The platelet count was fine. It was actually elevated because it's an acute phase reaction. So in setting of trauma, your platelets will kind of go up because your body's responding to that trauma. So based off of all of that, the mom telling me that there was no history of trauma, I'm seeing rib fractures, which are highly specific for abuse, corner fractures, which are highly specific for abuse, picture of a bruise on the scalp. I put in my consult note that these are consistent with child physical abuse. So that's all documented in my consult report based off of all of that history gathering, my physical exam, all of the laboratory data, all of the imaging data that we had at that time.
And was that your diagnosis?
It was, yes, and still is, yes.
And has the child had any testing done for osteogenesis imperfecta?
Yes, so I ordered that. So there is a blood test that we can send off. Early in my career, we couldn't do a blood test. You'd actually have to do a skin biopsy and send it off. Now we do blood testing. So the reason that we send that is because I know that it's going to be asked. It's going to come up, especially in court. I didn't have a high clinical suspicion for it because her bones look normal. These are not fractures that we see in kids who have osteogenesis imperfecta. You don't get corner fractures. Where we see kids fracture with OI, as we call it, is once they start becoming more mobile, you start to see that their weight-bearing bones, so like their thigh bone, the femur, starts to bend. They wind up getting fractures there. In the long bones is the most common place where they're going to get it. It's not going to be at the ends of the bones where you have the growth plate, which is where her fractures were, and then the rib fractures. So sent that off. We sent it to a lab at the University of Washington because they have the largest database of patients who they've looked at for any kind of concerns of osteogenesis imperfecta. And the reason we do that is because if you use a different lab that doesn't have as many folks in their database, if they see a little change in a gene, they may not know how to interpret that. They may say, well, there's this change here, but we don't know if that is causing any kind of problems to the body. So since they have the largest database, that's who our geneticists recommend that we use, so we always send it there. And that came back. It takes, a couple months to come back, or maybe 4 to 6 weeks if we're on the lucky side. But it takes time to come back. And that did return, and everything on that in our screen for osteogenesis imperfecta, the recommended screen, did come back as no abnormalities. So we had that genetic screen. Then we also had subsequent x-rays. So whenever we get a skeletal survey, we get what we call a follow-up skeletal survey, or a FUSS, F-U-S-S. And we get that in about 2 to 3 weeks. And so I recommended that she come back and get this follow-up skeletal survey. And the reason we do that is because sometimes we'll miss very subtle fractures on the initial x-rays, and then we give the body time to start healing. And then you can pick it up much more easily on the follow-up x-rays. And so we did that, and we actually were able to pick up, so that was done on June 23rd, 2023. And we also had her come to our clinic, and she was seen by one of my colleagues. On that one, we picked up an additional corner fracture, and then the radiologist went back and looked at the initial skeletal survey and said, oh yeah, it was there, it was just very subtle. And that was on the distal left tibia, so that's the shin bone down by the ankle, so the ankle end of the left tibia. We saw continued healing of that, of the rib fractures, as well as the other corner fractures and that fracture in the foot. So it confirmed that there was that fracture in the foot. The only thing that we didn't see was that possible 8th rib fracture, so we didn't feel comfortable saying that that was a real finding on the initial skeletal survey. So those were the follow-up labs that were done, but then Emma did wind up coming back to the hospital in July. So she came back mid-July, and she had an additional workup for child physical abuse at that time. So she got another skeletal survey on July 11th, and then we did the follow-up for that one on July 31st. So she had a total of 4 skeletal surveys, so x-rays of all the bones in the body. Except for the one in June, the second one in June where we picked up that corner fracture of the distal left tibia, which was, when you looked at the first one on the 6th, it was there. We didn't pick up any new fractures. So that would also go against like having any kind of problem with your bones, because it wouldn't matter what environment you're in. If you have a problem with your bones, you're going to continue to fracture as you become more mobile. So typically we're not getting 4 skeletal surveys. In her case we did, because she presented in July with bruising on her feet, on the soles of her feet and on her leg. So that's why the workup was done again.
And was there any evidence of these being birth injuries?
No.
And how do you know that?
Yeah. So the corner fractures were all recent. We even had swelling that was, like the mom reported that swelling, the pediatrician detected that swelling on that right leg. These were recent fractures in the extremities. And then the rib fractures, it's very rare to get rib fractures from birth. She was already 2 months old. You'd expect that any kind of birth-related fracture would have almost completely healed by that point, if not completely healed. We don't see rib fractures in isolation with birth trauma, because when you wind up getting the fractures from birth, it's because you're having, usually it's like a shoulder, what we call shoulder dystocia. So if you're coming out head first, and the widest part is your shoulder girdle. So as you're birthing and trying to get the shoulders through, if you wind up getting a squeezing force there, you wind up breaking the clavicle. Is the most common bone that we see being fractured during birth. Sometimes we'll see like an arm or a leg actually get broken, but it's usually the clavicle. When we see rib fractures that have occurred during birth, it's described as a traumatic birth. There's usually some instrumentation, but when we see that, all the literature shows that you also have the clavicle being broken on the same side. So she never had, we didn't see any clavicle fracture, so I can say confidence that these are not birth-related injuries because they're at different points in time, not injuries that we see from birth in this pattern. And then we also had, cutaneous injuries as well. We had this bruising that was on the scalp behind the ear, and then when she came back in July, then we had additional bruising. So none of that would be birth-related. I did review her birth records. I did see that they did document that she had some bruising on her face during birth, but that was not what I was making my diagnosis on.
And so when you diagnosed this as non-accidental trauma, what were you basing it off of?
Sure, so multiple things. So it was the history that the mom provided, the photo that the mom showed me of the bruise behind the ear, the developmental capabilities of a 2-month-old, and what she told me that Emma was able to do. She told me that she's able to reach, follow, she smiles, she doesn't like tummy time, and that was really it, which is fine for a 2-month-old. So I combine that with the history that the mom provided of no trauma, the lab values that we have, the locations, the specificity of these kind of fractures that I'm seeing on the x-rays, and then, knowing the kind of forces that are required to cause those types of fractures, that she can't self-generate these. So it has to be an external force to her body to create these, because this is all trauma. Mom reported the 3-year-old cannot put their hands around a child's, infant's chest and squeeze to cause rib fractures, or, they don't weigh enough. They fall down on them to cause rib fracture. They don't have the strength to pull on the arms or in her case, in the legs, or have them flip about, or pick her up and cause those legs to flip around. There was no other history that was provided to me of any kind of trauma. Mom specifically said she didn't fall or drop, and I wouldn't expect to see these kind of injuries from a fall or a drop. It was based on all of that. Then it was, because she came back at the 2-3 week mark for that follow-up skeletal survey, reconfirmed things, that we didn't have any additional new injuries. Got the OI testing back, and that reconfirmed that there was nothing genetic, and she's been growing and developing well. So there's nothing inherently wrong with her body. All of those things factored into my initial diagnosis, and then my continued statement that diagnosis is to a reasonable degree of medical certainty, that's what she suffered from, that she was a victim of child physical abuse on at least 2 separate occasions.
Are these fractures that can be, you kind of touched on it, but are these fractures that can be caused by a parent trying to do bicycles to let gas out on this child?
No. So to get a corner fracture, you need to have either a twisting or a yanking force. So you wouldn't get that from bicycling. When a bone breaks, like the ribs, these corner fractures, it's going to hurt because there's nerves that, if anyone's broken a bone, especially a rib, that really hurts, and you can't stabilize that when you're taking a breath. It's painful. So at the time when the fractures occurred, I would expect Emma to exhibit signs of pain. And if anybody was in that room when those fractures occurred, they would recognize that that was painful to her. This wouldn't be something that she would be laughing or giggling about when those forces were applied to her body. So I would expect that whoever caused the injuries would recognize that this was painful to her, and if anybody was around and saw that, they would recognize that that was a painful action to place on Emma's body.
And are these, so let me go back. Are you, have you seen children with metabolic bone disease or other conditions of the bone?
Yes.
And based on your review of all the medical labs as well as surveys, did Emma exhibit any of those similarities?
No.
What is the purpose of getting the bone lab and trauma lab done?
Yeah, so like I mentioned earlier, we get all of the trauma labs. We want to make sure that we're evaluating her entire body, making sure that we're not missing anything. So that's why we do all of those trauma labs, and that's why it's built into our pathway. We get the bone labs because we want to assess the bone health. You know, to make a diagnosis of, like, if there's a problem with the bones, we'd expect to see, we're going to have, for instance, for Emma, because she has a low vitamin D. That in isolation indicates that her vitamin D level is low. It doesn't indicate that she has what we call rickets. She doesn't have a systemic response to that low vitamin D, where her body is trying to pull the calcium out of the bones to keep the levels higher, at normal levels in the blood. The way that happens is your parathyroid hormone goes up, hers was normal, and then you start leaching the calcium from the bone. And if you had that, you would see changes to all the bones, because it's a change in how your body is responding to that. It wouldn't just be isolated that you have a change at the end of your, like your left tibia, and just around your right knee. You would get changes. We look for it at the wrists, in particular, where you wind up getting cupping and fraying because you're seeing that the bone is being demineralized. So there's not anything to indicate that she has any kind of metabolic bone disease. And like I mentioned earlier, there's nothing to indicate that she has osteogenesis imperfecta, the most common genetic condition that we talk about in child abuse when we talk about fractures. So that's why we're looking for those things. So there wasn't any other medical condition for these. And these are traumatic injuries, so it's trauma to the body. So what is that trauma? I have yet to be told about some type of significant trauma to her body that would generate these type of forces to cause these multiple fractures, as well as the bruises that I saw on the picture, as well as what we saw when she came back, when my fellow and one of my other colleagues saw and evaluated Emma. So Emma was actually evaluated by not just myself during that initial hospitalization, and she was seen by my colleague in the clinic, and then she was seen by our senior fellow with the other child abuse pediatrician when she was readmitted in July. So she was actually seen by all three of the child abuse pediatricians who were covering, as well as one of our fellows.
And now going back to the force applied, is there a difference between baby bones and adult bones?
Yeah, there is. So we weren't all born at this height, right? So your bones have to be able to grow. So infant bones have open growth plates at the ends, but they also have a higher percentage of cartilage than adult bones. So cartilage is like your ear, your nose, it's flexible. So infant bones are actually a little softer and bendier than adult bones until they become fully ossified. So those are the major differences between pediatric bones and adult bones.
So when there is a fracture to a baby bone, what does that indicate to you?
Yeah, I mean that there was a force applied to the bone that was greater than that bone could withstand, right? So, because there's different types of fractures. So we kind of use this blanket term fracture, meaning a broken bone. But we have fractures that we only see in infant bones, like these classic metaphyseal lesions. We can't get those because our growth plates are no longer open. you can have a fracture that goes straight across the bone, like a transverse fracture at an angle, which would be an oblique fracture, a spiral fracture where it's kind of like twisting around the bone. Those will tell you about the different forces that were applied to that bone to cause them to fail. We know that bones will fail. It's easier to break a bone in a spiral fashion than in a transverse fashion. So you can't just say it's a certain amount of force. But I can tell you that it's more force than, I would expect an adult or teenager to use when handling a baby if it's causing the bones to break. This would be a painful force to the baby. I would expect that if someone was witnessing this, that they would say, hang on, that is not good for the baby. This is more force than I would expect a reasonable adult to use when handling a baby.
Nothing further.
Thank you. We're talking a lot.
All right, you may proceed.
And he just wanted to make sure he got his water.
Thank you.
All right, good morning, Dr. Messner.
Good morning.
Okay, so you have been qualified as a child abuse pediatrician. When did this specialty of child abuse pediatrics begin?
So, formally recognized by the American Board of Pediatrics in 2009, but there's been literature on child abuse going back to the 40s and 50s.
Okay, so before y'all were using anesthesia on babies when you operated on them?
I don't understand your question.
No.
So I'm not an anesthesiologist, and we do use anesthesia. Our anesthesiologists and nurse anesthetists do use anesthesia on infants and babies.
And that has been the medical protocol for at least 40 to 50 years at this point, right?
Oh, I'm not certain. I would, like I said, I'm not an anesthesiologist, but current practice is yes, and like when I was born, yes. So.
Well, you mentioned going back to the 40s and 50s, so I assume, as one of the first qualified, board-certified child abuse pediatricians, that you have gone into the history of how all this developed and how the medical profession can best serve and keep children safe and healthy, right?
Yes, I'm just not certain about the anesthesia question.
All right, so it was formally recognized in 2009, but you were already studying child abuse pediatrics earlier than that, right?
So, correct. I was learning about child abuse starting back in medical school during my pediatric residency, and then I was practicing. So I was on the child abuse team down at the University of Florida in Gainesville. So I was a practicing pediatrician. I was practicing in the field of child abuse. It was just preceded the board certification.
And so you said 100% of your practice at this point is handling cases where there is a suspicion of child abuse?
That's correct.
All right, so at what point did you make the diagnosis that Emma Hernandez was the victim of child abuse?
Sure, so like I stated earlier, if you look at my consult, which was from the 7th of June, it's part of her medical record. The last sentence says, overall, the findings are consistent with child physical abuse on at least 2 separate occasions. So it was at the time of my consult for the reasons that I mentioned earlier.
Okay, well, so we heard from one of the previous witnesses about the difference between an impression that is presented in a consult and a formal diagnosis. Is that a difference that you are familiar with and put into your records?
No, so that was my diagnosis. If you're referring to like diagnosis codes and things like that, that's different, but that was my diagnosis at that time.
Okay, so your testimony now is that you made the diagnosis of child abuse on June 7th of 2023 for Emma Hernandez.
That's correct.
Okay. And then you saw Emma Hernandez again in July of 2023, right?
No,
You did not see her at all on the July visit?
I did not. So when she came back to the hospital, so she came to our clinic in June, was seen by my colleague, Dr. Pena, and then in July, she was seen in the hospital by our fellow, Dr. Chang, and the attending physician. So when you're a fellow, you have an attending who is overseeing all of your work, and then we sign off on that. So we also see the patients. We make sure the documentation is correct, and that's in any setting, so in the clinic or in the hospital. She was seen in the hospital by Dr. Chang, and his attending physician was Dr. Brown.
Okay, so Dr. Ching and Dr. Brown saw Emma Hernandez in July of 2023. Did you see Emma Hernandez when she was brought back to the hospital in August of 2023 after the daycare she was in noticed discoloration on her face after a nap?
I did not, no.
Okay. So we heard from one of the nurse practitioners a little bit earlier about the way that different teams work together at CHOA and how an individual patient is kind of followed throughout the process. So was there any doctor who was responsible for Emma's case kind of throughout her progress?
If I'm understanding you correctly, there was not like one particular physician who saw her from the first time she presented to the emergency room on June 6, 2023 until August of 2023. So she would have been seen by multiple teams. So the emergency room physician, whoever was on that day, whoever was on for trauma, if there was a concern of trauma, if she was admitted to the hospitalist service, then it would have been the hospitalist. If they actually had a consult from my service, it would be whoever was on for consults that day. So when she first came in, I was on for consults. When she came back in July, then it was Dr. Chang and Dr. Brown. So that's typical of any patient who comes to the hospital.
I'm so sorry, just one moment. Ever since I got the new update, I'm not stop buzzing. So there has been no doctor that has seen Emma Hernandez on all of the different occasions that she has been brought back to CHOA, even within the summer of 2023?
From my team, no. I can't state that there wasn't another physician who saw her each time. I don't have her complete record right in front of me.
Okay. Well, so when you testified a little bit earlier in response to the state's question, you had a lot of detailed information about the June clinic visits and the July skeletal surveys. So at what point did you become familiar with the information about Emma Hernandez's subsequent hospitalizations after your diagnosis of child abuse and after she was removed from the care of her parents the next day?
Yeah, so when she came to clinic, I was aware of that visit. We're a small team, and I had ordered that follow-up skeletal survey. So I knew about that. I knew when she came back in July because my fellow reached out to me and said, you know, Emma just came back to the hospital with new bruises. And he knew that I had done the consult before because you pull it up in the record. So that's part of what we do is we look back. So when I was aware then. And then I knew about the follow-up skeletal survey when that resulted. I knew about the OI testing when that came back because I had ordered that. It didn't come back until I think September. So there's different ways that like you find that I found out about her. It was primarily through the studies when those resulted.
Well, so you made the diagnosis of child abuse 3 months before the OI labs came back.
That's correct.
And how about the subsequent genetic testing that was done at Emory and other locations in spring of 2024?
So I did get to see those. That was sent to me, I believe it was through either DFAX or through the DA's office, because that was not done through our hospital system. So that's the Invitae lab. And so I did get a copy of that. And it did not change my diagnosis.
Okay, so you got a copy of the Invitae and then also the Gene DX and everything that Dr. William Wilcox was relying on over at Emory?
I'm not sure about the second one that you mentioned, but I did know that Dr. Wilcox, who's our geneticist over at Emory, had seen Emma and also said she does not have a genetic condition to cause these fractures. So that I'm aware of. I don't know if I ever saw it. I'm not familiar with the second lab that you're mentioning.
Well, so did you have the opportunity to read Dr. Wilcox's report or actually view his findings on the testing that he did?
At some point, yes. I can't recall right now when that was.
And so then you're aware then that even your geneticist over at Emory that y'all at CHOA worked with found that Emma had at least 4 genetic variants and mutations.
So to answer that, yes, but he also said that they are not pathogenic. They are not causing any problems to her. It's not uncommon to find variants, and like I mentioned earlier, that is why we work with our geneticists very closely, and that's why we use the University of Washington lab, and that's why we do that specific panel for the OI testing. So I know that there was other lab testing that was done at outside labs, was presented to Dr. Wilcox. That did not, I mean, yes, there were some variants there, but they were not things that would cause any changes to the bones to cause propensity to fracture, increased fracture risk. So he never diagnosed her with any kind of genetic condition. Yes.
Okay. And you kind of laughed a little bit when I asked that question. Was there something funny about the genetic results that Emma Hernandez received?
No, it was just a response to knowing that we have additional lab tests. We're sending out these bigger panels, and that there was something that was abnormal in them, but but abnormal doesn't mean that it's problematic or that it's pathologic, right? So that was just me kind of processing the question about, hey, did you know that there's 4 abnormal things in this? Yes, but abnormal doesn't mean that it's a problem, right? So that's why I made that comment.
Okay, well, and of course, I would agree with you that abnormal doesn't mean that it's a problem, but are you testifying here today that it's your belief that the report performed by Dr. William Wilcox did not report that any of the genetic variants were pathogenic?
She can ask questions to Dr. Wilcox about that. That's not an appropriate question to ask this doctor.
And Your Honor, I would disagree. He's qualified as an expert, and he's the one who made the diagnosis in Emma Hernandez's case, and he has had no problems testifying about the results.
I'm going to let you ask the witness that question, and if there's a report that you're referring to, it needs to be in evidence. Okay?
Okay, it's the state's witness that they're going to be calling for Dr. Wilcox.
Yeah. But if you're referring to a report, okay, you may have to show it to the doctor.
Oh, yes, and I'm happy to. So if I could approach the witness?
You got it.
So we've got.
So you're,
Gonna tender it?
I mean, I guess we can.
Refresh it right.
No, I'm going to speak to this witness about this expert.
Judge just said tender it.
I think you wanted me to go ahead and show the witness what I was referring to,
That's
which
correct.
is the report of the state's expert witness.
If that's the report you're referring to, I don't know what report you're referring to. If you're referring to a report, the witness has an opportunity to look at that report.
Certainly, Your Honor,
Okay.
if
So
I
I'll
could
let you-
approach now. Thank you. Dr. Messner, I'm showing you, this is the Emory Clinic Certificate of Authenticity, Dr. Wilcox's report. You would agree this says Dr. William Wilcox, right? Genetic consult? Okay. So if you could note what is in the report regarding whether or not any of Emma Hernandez's genetic variants are likely pathogenic or pathogenic.
Okay. I was trying to find Dr. Wilcox's impression, but I'll let him speak to that when he is on the stand. So it does have that she went extensive genetic testing, proband only whole exome sequence was ordered, and it revealed the following variants in their classifications. So there's one that says likely pathogenic, but then it says heterozygous. So that means it's one copy of it. Then there's a variant of unknown significance, heterozygous, and then it says pathogenic, heterozygous, carrier. So again, one copy of it. That is from this whole exome sequencing. When you look at the one from Invitae, it says that there's a, doesn't mention those, it says that the variants that were detected from that prior one, they were classified as following in it says Invitae, which is this other lab, classified them as a variant of unknown significance, and this other one as likely benign. And then the one that we sent to University of Washington said no abnormalities on the labs that they did. So again, you have to know what these
Well, if I could just, if you're finished with the report, and then we could continue with the questioning regarding whether or not there were any pathogenic variants discovered in Emma Hernandez's medical record. And at this point, can you agree that in fact, several of the genetic mutations that were discovered in Emma Hernandez were found to be likely pathogenic and pathogenic?
There was one of each of those in the one lab, and then they were classified differently on the other lab. Yes, that's what it says, but it's, you need to take it in context, and they were heterozygous.
Well, and absolutely. I mean, obviously, we want to get the maximum context possible, but you previously testified that none of the genetic variants that Emma Hernandez had were pathogenic, correct?
Correct, and I was using that in terms of meaning that it was expressive, that the genes being expressed were pathogenic, that it was causing problems to the bone, which they are not.
Okay, so I understand that, but we're trying to get to your reasoning and your conclusions about this, and so we at least need to agree on the facts that we're relying on. And so can we agree on the facts that Emma Hernandez has multiple genetic variants?
Been asked and answered.
I'll let you address this one more time, then we'll move forward off of it. You may ask the question.
Do you agree that Emma Hernandez was found to have at least 4 genetic variants through genetic testing?
Yes.
Do you agree that one of those was classified by the geneticist that you work with at Emory Healthcare as likely pathogenic?
No, it was not classified by him as, it was classified by the lab as likely pathogenic.
So would you agree that it was classified by the lab as likely pathogenic?
Yes.
And would you agree that another one of the mutations that she had was also classified as pathogenic?
By the lab, yes.
Okay. So obviously you have some opinions on whether or not they actually were causing problems for Emma Hernandez, but there is no dispute that she has genetic variants that are classified by the laboratories that you have just referenced as reliable and where y'all send your genetic testing results to as pathogenic and likely pathogenic, as well as variant of unknown significance.
Incorrect. They were not sent to the University of Washington. These are from different labs, so I can't, I believe these were actually ordered by Dr. Krishnamurthy. That's a mischaracterization to say that it's from the labs that we rely on, which is University of Washington.
Do you know about those test results being sent to the University of Washington to see if they have any additional information or might be able to further
Objection
clarify?
testifying.
No, I'm just asking.
You can answer if you had knowledge, Doctor.
I'm sorry, could you repeat the question, please?
Do you know if any of this information was sent to University of Washington to see if, I don't know, maybe this lab got it wrong somehow?
No. So, as I mentioned before, when we do our genetic testing specifically for osteogenesis imperfecta, we do a specific panel. So it's not like we're like testing for everything. It's specific for osteogenesis imperfecta. We use the University of Washington because they have the biggest database of folks who they've tested for those genetic mutations. So that way we don't get these variants of unknown significance at a higher rate because we know what the significance of it is. Well, the University of Washington does. So that's why they report it that way. That's the most that I can speak of to that. I will defer to the geneticist about these other labs, what those other genetic mutations, where those are on the chromosomes. But the bottom line is that there wasn't anything based on our laboratory testing were based on my understanding of Dr. Wilcox's interpretations of his exam, the test that he had available to him, that there is anything wrong with Emma's genes that would cause her to have increased fractures. And we haven't seen any more fractures. We have 4 sets of x-rays where, in the first set we had those 3 ribs, and then we had 7 fractures in 2 months of life. If you look at that fracture rate, you would expect that she would have at least 1 more fracture by the time she's, the last set of x-rays were done. And she didn't have any more. And I haven't been told about any additional fractures. And we expect to see kids as they become more mobile, if they have a problem with their bones, as they're about, moving about, they're falling off of things, jumping off of things. She's over 2 years old now, that she would continue to fracture if there was a problem with her bones, because your genes aren't going to change. Your genetic makeup is going to stay the same.
Well, right, your genetic makeup is going to stay the same, and as your bones are being formed in utero, you would agree that collagen production is an important part of bone growth and formation, would you not?
Yes.
So if there is an abnormality on a collagen-producing gene, do you think it is impossible that that would have any impact on bone growth, development, and health?
No, that's not what I'm saying. I mean, if you have a problem with your collagen, which is your building block of your bones and your connective tissues, if your genetic makeup has a problem with how your collagen is being formed, that's going to continue. It's not going to go away. So whether you're in utero, you're 2 months old, you're 2 years old, you're 20 years old, you're still going to have that problem.
And actually, okay, so I suppose, have you done, in the course of your work in child abuse pediatrics, have you done any research or studying regarding bone growth and development?
Personally, no, I have not. I'm not a researcher, so I haven't personally done any research on that. I'm familiar with the literature.
Well, I mean, you just mentioned something like a fracture rate. What literature are you relying on for discussion of a fracture rate as something relevant for the jury's consideration?
So I was using that as a demonstrable, right? So you just think about a child who is not even mobile yet, right? She's only 2 months old and she had all those fractures. If we're saying that there's something wrong with her bones, there's something wrong with the genetic makeup of her collagen, and yet she had that many fractures at that young of an age without being even able to roll over, and then has no fractures after she becomes able to roll over, to crawl, to walk, to jump. That defies logic. So that's what I was trying to get across.
So you acknowledge the role that vitamin D and vitamin D deficiencies play in bone growth and health, right?
Yes.
Okay. And you, of course, have acknowledged that Emma Hernandez had a very low vitamin D level in June of 2023.
I never said it was very low. It was less than 20. It was 15.7, I believe. Let's see. But it was low. But again, we didn't have any other laboratory changes associated with that. And more importantly, we didn't have any radiographic changes. So I'd say, to a reasonable degree of medical certainty, there was not any impact of that low vitamin D to her bones. And this has actually been studied where they looked at kids who have low vitamin D and fractures to see if there was look at the vitamin D level of kids who have fractures when there's been a diagnosis of abuse and there's been a diagnosis of an accident. And you see the same levels of vitamin D. So you have low vitamin D in both groups. It's at the same rate. So you can't say that, these kids who are accidentally fracturing, that it's, you can't attribute it to the low vitamin D. And in Emma's case, we didn't see any changes to the bones. We didn't see any changes to the parathyroid hormone. We didn't see any changes to the alkaline phosphatase. Her magnesium, her calcium, her phosphorus, all of these building blocks of the bone were all normal. So there wasn't a response in the body. And like I mentioned earlier, this is a systemic thing. Like, so if you're saying that there's a problem with metabolically, with how her bones form, it would impact all of the bones. It's not like you have, just one extremity getting these minerals in a deficient concentration, and the rest of the bones all have normal concentrations of it. That's just not how our circulation works. It's not how our bodies work. There's no evidence of metabolic bone disease with Emma.
And you've previously testified in cases involving children with unexplained fractures, right?
Sure, yes.
And in cases where those children have had normal vitamin D levels, you have cited that as a reason that the fractures are caused by child abuse, correct?
No. I would never say that a normal vitamin D level led to a child having fractures from abuse.
Well, right. You're not saying that a normal vitamin D level would lead to it, but in cases where you have been speaking to juries in similar situations like this, defending your diagnosis of child abuse after the child has been taken away by the family, you have said the child's vitamin D was normal, so that is one of the factors that we know that this fracture was caused by child abuse and not any problem with the bones, correct?
I'd have to see the specific transcript on that, but I can tell you that the diagnosis is not made solely based on one nugget of information, right? So it's based off of all of these things that I've been sharing with you. It's based on the history, the family history, the social history, the history of present illness, the physical exam findings, historical documentation of any abnormal physical exam findings, the laboratory studies, the imaging studies, and then, the best litmus test is what we see happens when, if a child, if we make a diagnosis, determination that there's abuse, and if that child is removed from that environment, then if we don't see, continued injuries, that is an additional factor that validates that diagnosis.
But Emma Hernandez, of course, was removed from that environment on June 8th of 2023, and she came back to CHOA in July with unexplained markings on her.
That's correct.
And then she came back to CHOA in August of 2023 with additional unexplained markings, correct?
In August, I guess it depends what you're saying, unexplained markings. So in July, yes, she came back with bruises. There was not any bruising that I'm aware of from August. And she was placed in relative custody, which means that it's relative. It was the maternal aunt and uncle, and then when that was up until July, and then DFCS changed the custody to a non-relative. I don't know who all had. Excuse me?
Before August 2023, right? when the daycare reported discoloration?
I'm not aware of anything from the daycare or any documentation of that, or, you know, and I don't know what you mean by discoloration, but we have documented bruises that persisted while in the hospital. Not like some temporary changing of the color, something we call acrocyanosis. This is distinct, different from that. So bruises, as well as the bruise that mom documented, and then mom told me about other bruises. All of that occurred up until July. And then in July, when she represented with the bruises that my fellow and Dr. Brown saw in the hospital, then there was a change in whose care she was under. It was not under a relative of the parents. That was a DFCS decision, and you know, it's my understanding that that was to limit the possibility that there was any, you know, contact by the original household members when she came in with all of those fractures.
So let's turn to your relationship with DFCS, because you're testifying now about information that you received from DFCS about things that happened after you were no longer caring for Emma Hernandez, right?
Right, so I'm testifying about information that, you know, I've been preparing for this trial. I've been told about a lot of different aspects of this case. So I guess in that aspect, yes.
So about how, let's go back to June 7th. Did you see Emma Hernandez on June 6th?
No.
So you saw Emma Hernandez one time before you made this diagnosis, right?
I did, yes.
About how long did you spend with her and her mom that day?
So I documented, oh, that's not my note, on my consult note, 115 minutes.
Well, I mean, I think you didn't indicate that you spent 115 minutes with Emma and her mom, did you? You said that that was the amount of time you spent on Emma's case in its entirety, right?
Right, so that includes reviewing the records, going down to radiology. So yes, I can't tell you, it would be less than 115 minutes, but it wouldn't have been, you know, 5. I spent the time to sit there with mom. We had to, she was there the whole time I was examining her. She was there for all of the history gathering, made sure that all of her questions were answered. And like I mentioned, we had the interpreter on the cryophone the whole time. But I can't tell you how many minutes I was just in that hospital room with mom.
Well, I'm sure, having participated in a number of these cases, I'm sure you understand the critical importance of the medical doctor's diagnosis of non-accidental trauma in all of the rest of the proceedings that take place in a situation like this, correct?
Sure.
So you understand the number of people in law enforcement and social work and Department of Family and Children's Services who don't make their own independent determination whether there was child abuse.
It's an argument.
I'm asking a cross-examination question to the witness, Your Honor.
I would just ask that you just ask the question and I'll let you ask the question, go ahead.
Thank you, Your Honor. I'll see if I can clean it up and make it as direct as possible.
I just don't know if you're going outside of his knowledge, so I just ask you lay the foundation or what he knows, okay?
Let me go back. You were on the child advocacy team at CHOA, is that correct?
That's how we're referred to when they place an order. It's child advocacy medical. But yeah, I'm a child abuse pediatrician.
So you are aware that Department of Family and Children Services relies on your diagnosis in determining the actions that they will take with regard to a family, correct?
To a degree, yes.
To what degree?
I mean, it depends on the case. You know, I've had cases where, you know, let's say a child came in and they had a skull fracture. Defects are called. Defects did a removal, and then I come in and, you know, do the evaluation. I'm like, this could be accidental, and then it's up to them. You know, I relay that information to them. I've had cases where I said, this is child abuse, and that child remains in the same household. So I'll staff it with them, I'll give them the information, but it's up to them about whether or not there's going to be any changes in the environment that the child is in. So there's defects in law enforcement. So defects is responsible for the safety of that child, whether that be, you know, that it's an unsafe home environment, like uncleanly, they don't have food, or there's abuse going on in that house, or suspected abuse, then that's going to be up to defects. If there's you know, concern that a crime has been committed, then law enforcement is going to get involved. In Emma's case, before I ever saw her on the 7th, both defects and law enforcement had met with mom. So that occurred separate and prior to my consult.
And so I guess, then I don't want to put words in your mouth, but you understand that you have a primary responsibility with the diagnosis, but you believe there are other people making decisions based on factors other than your diagnosis when determining what the fate of a child and a family should be?
I suppose that's accurate.
All right, so let's go back to that 115 minutes on June 7th.
Okay.
So, all right. So you conducted a physical exam of Emma Hernandez, right?
That's correct.
Okay. And in that exam, you did not notice any abnormalities other than a slight swelling to the right leg.
No, what I testified to and what I have documented in my physical exam is that she has a splint on her right leg. And that was placed prior to my exam.
But so you did not observe any other problematic findings with regard to Emma Hernandez?
That's correct.
And y'all have ordered a head CT scan, right?
That had already been completed, yes.
Okay. And what were the results of that head CT scan?
Yeah, so there was some swelling on her scalp. I didn't appreciate that when I palpated her scalp. Sometimes we can see that on the x-rays, and you can't really feel it that well. So there was nothing wrong with her bones of her skull, nothing wrong with her brain, nothing wrong with the space outside of her brain, so there was no blood there or anything like that.
And so I believe you looked at the picture that was provided by Emma Hernandez's family of the marking behind her ear, correct?
Yes.
Okay. And it is your belief that this was an inflicted injury upon Emma Hernandez?
Well, there was no history of trauma. Again, mom did not report any history of trauma. Now, if someone could tell me if there was trauma,
Your Honor, if I could direct the witness to, I'm trying to let him go as much as possible. He is an expert, but we also have limited time. And so I'm just asking if your impression is that that was inflicted trauma on Emma Hernandez's head.
Doctor, you can give your answer, but you also can give your explanation. So.
okay.
Thank you, Your Honor.
Thank you.
Until proven otherwise, yes.
Well, so it is your belief then that someone hit Emma Hernandez in the back of her skull so hard that it caused that bruise, correct?
I don't believe I said that.
Okay, well, what do you believe happened to Emma Hernandez to cause that marking that you used in your report and diagnosis?
Sure. So there was trauma to Emma's head, right? So she has bruise behind her ear. We know that, children, there's a great mnemonic that we use called 10-4 faces P. And that's looking at places where we don't typically see injuries on a child from normal play. And it's validated up to 4 years of age. Now, in Emma's case, she's less than 4 months of age. So the 10-4 faces P is different regions of the body. Also part of that is having any kind of mark on a child who's less than 4 months of age. And that's because they're not mobile yet. So it's not saying that it's a absolute, but to have this kind of bruising behind the ear, I would expect someone to be able to tell me what that trauma was, because Emma wouldn't be able to self-inflict this. And then the mother also reported to me additional trauma to the neck, which is one of those regions that's protected. We even would consider that concerning up till 4 years of age. On the torso, that's the T in that 10. TEN is torso, ears, neck. So mom is reporting to me that there was bruising on the torso as well as the neck in this infant who's less than 4 months of age, that it lasted for 4 days, bruising, right? This is not some vascular phenomenon, something we call acrocyanosis. You wouldn't even get it in these locations. This is not acrocyanosis behind her ear. This is bruising. And mom showed this to me. So yes, I did take that into account because there's this history of trauma that caused these injuries. There's nothing wrong with her blood that makes it more likely to bleed, like she doesn't have hemophilia, she doesn't have a problem with her platelets. We looked into that. Yet we're seeing these cutaneous or on the surface signs of trauma. And then we found skeletal trauma, right, when we did those x-rays. So all of that factors into my diagnosis.
But you're saying somebody hit a tiny little baby in the head so hard that it caused a large dark bruise, and then y'all found no problematic evidence of such an injury on your head CT scan that was performed at CHOA. No fractures, no bleeding on the brain, no findings on the neuro exam, nothing else that would explain the amount of force you are claiming was applied to Emma Hernandez's tiny little head.
So I don't recall ever testifying to the amount of force or someone hitting her in the head with such force that it would cause this large bruise. What we do have is a bruise to the back of the head. We did have soft tissue swelling on that CT scan, so we do actually have signs of injury in the soft tissues, which is where this is. It's in the skin. Now, could this have tracked down? Absolutely. We see that all the time, like kids who fall and they bonk their heads and they get a big goose egg and then they wind up with black eyes because the blood is like tracked down into the soft tissues and it's tracked down behind the ear. I can't tell you what exactly caused this. Could someone have hit her in the head? Absolutely. Could someone have hit her in the head with something? Absolutely. Could they have hit her head into something? Absolutely. Any of those things are possible. And we see that you can have those kind of injuries without necessarily fracturing the skull, without having blood around the brain. Thank goodness her brain was fine. But we look for those things. And we know that the neuro exam is not reliable less than 6 months of age. So that's why we get the head CT in these young children who come in with injuries when we're concerned about non-accidental trauma. So that's why she got the head CT. And it did show that swelling in the soft tissues. Now, this is bruising behind your ear. So it's additional trauma, prior trauma.
Higher trauma?
Prior.
Prior trauma. Okay.
Or historical. Like this Mom photo documented this herself.
Okay. So mom photo documented this herself, gave it to you, gave it to DFCS, gave it to law enforcement, correct?
I'm not sure about law enforcement, but yeah, and she didn't give it to me, she gave it to our DFCS liaison, and then, because she emailed it. But we did place it in her chart.
So, do you have any way of distinguishing between a parent who is worried about unexplained symptoms on their child and a secret abuser who is then bringing the victim of their abuse in for repeated medical care?
No, in my, over 2 decades doing this, I've seen all sorts of things. I've seen parents on camera injuring their child, and then they bring them in. I've seen parents, caregivers, babysitters who have injured children and then reported it to me or to law enforcement or to DFCS. They've confessed to it. I've seen children who have been injured and nobody says anything about it. So I've seen the gamut. I've seen, grandmothers seriously injure children. I've seen babysitters. I've seen unrelated folks seriously injure children, as well as the parents or the step-parents. So I can't tell you who did this and whether that person would be the one who brought them in to seek medical care, because we've absolutely seen that. That's not uncommon for someone who's especially someone who has a relationship with that child and then realizes that there's something abnormal, and then they bring them in for medical care, but they may not be forthcoming about how that injury occurred. So I can't tell you who did this. I can tell you who didn't do it. It wasn't Emma. It wasn't her 3-year-old sibling. But there, to your question about whether it's someone who sought repeated medical care, I can't tell you if that you could rule that person out, because if they're physically capable of doing this, then yes, that's not a characteristic that I would factor into whether I'm making a diagnosis of abuse or not. It's based off of the history that's provided and everything that I've kind of stated to you guys ad nauseum.
Okay. So, but my question was if you have a way to distinguish between a woman bringing her child in because she wants help with unexplained medical circumstances and an abuser bringing their child in. What is your way of distinguishing between this?
I hope I conveyed to you all that there isn't a way to distinguish that.
And is that you don't think there's any way to distinguish it at all, or just not something that you're able to do?
Well, I definitely am not able to do that. That isn't. I don't know if there's someone else. I mean, that's why there's an investigation. That's why there are folks who are trained in investigating, whether that be for DFCS or for law enforcement. That is their role. So they may be able to do that, looking at all the different aspects of things. That is not my role in this by any means. I make the diagnosis. And like I said, in Emma's case, I stand by that diagnosis.
Okay. So it looks like, a number of doctors saw Emma at CHOA before you did, correct? Like Dr. Yu and Dr. Clifton and Dr. O, since apparently other folks have trouble pronouncing these names too.
Okay.
So you are aware of these other doctors who saw Emma before you, correct?
I can't say specifics. Again, I don't have the entire medical record here in front of me, but yes, she was absolutely seen by other medical providers, other physicians, as well as advanced practice providers prior to my consult, because I didn't do my consult until the 7th. She came in on the 6th of June.
So did you talk to any of the doctors who had already seen, examined, and in the case of Dr. O, recommended and treated Emma?
I reviewed the notes that were in the record. I don't believe all of them were still physically like at the hospital. So no, I likely spoke with Amber from trauma. I can't recall any other specifics, and I wouldn't want to misstate anything.
Certainly. So where in the record would we find your diagnosis of non-accidental trauma?
Well, if you read that last line of my consult note, it says, overall, these findings are consistent. Overall, the findings are consistent with child physical abuse on at least 2 separate occasions, so right there.
Okay. Well, so several other doctors in the record have placed medical attestations, such as Dr. Clifton and Dr. O. Did you place such an attestation into the record?
So you place no, because you place an attestation like when my fellow, if a fellow sees it, then we're attesting that what they documented was correct. So that's when you would do the attestation or a post-signature. As an attending physician, I don't need to attest my documentation.
Okay. So you're saying that the attestations are only made when there's the supervision of a resident or a fellow?
Or an advanced practice provider, yes.
Okay. So when Dr. Clifton made his attestation on June 6, 2023 at 7:52 p.m. From the Division of Pediatric Surgery, who made the decision to admit, who was he supervising, or why was he making that attestation?
I'd have to see the note. I have no idea.
You want me to should
That's right.
Here, Dr. Where did?
read that?
Yeah, so that's under Amber Borders' note.
It's the attestation signed by Clifton Matthew S. MD.
Yeah, so he had attested Amber's note.
Okay. So that's attesting to a note from someone else?
Yes.
Okay. And then how about Dr. O's attestation?
Yeah, so it says here. So if you read it, it says progress note. It says progress notes by, and I'll spell this for you because I don't even know how to pronounce it. NWAKIBU, comma UZOMAAMD, and then underneath that it says attested, signed by Dr. O. So she's attesting Dr. Nwabiku's note.
I think I also pronounced it a little bit wrong. Okay, so.
Because that is one of the ortho residents or fellows. And that's how we do things in medicine. It's common. We need to attest, like if you're using a advanced practice provider as a physician extender, or you're someone's in training, then you're going to attest the notes.
Okay, so you do not have an attestation in the record, and you do not have a formal diagnosis in the medical record. You just have your impression and consult notes.
So correct, I did not attest my own note. I stand by my note. We just document it. It's in the medical record. The medical record is a legal document, and it has my diagnosis in it. So
Can you just direct me to the page that you consider your diagnosis
This has been asked and answered.
I think you stated it before. Doctor, if you'd be helpful, move things along, please.
Thank you, Your Honor.
It's the last page of before my recommendations, under my impression, it's part of my impression. So the way the medical record works, like whenever we do a consult note, and I can't tell you what page it's on in your pile of papers because I just printed out my note individually, so it's on page, like this is 6 pages, and we know the medical records are going to be, volumes of pages. So it's page 5 of my note here. And the way that a medical record, a consult note, the way these flow, and this is very standard documentation in the medical records, it starts off with, like mine here, it says consult orders, like so who ordered this consult? And that was by Amber Borders on 6/6 at 18:43. So it's 6:43 p.m. She placed that order, and then I did the consult on the following day on the 7th. And then it says it's a child protection team consult, the name of the patient, all of these things. Then it goes through the history of present illness on the hospital course to date, then the past medical surgical history, the family social history, etc. Documents my physical exam, and then at the very end, we do an impression and recommendations. So if you're doing a consult, you'll do an impression, which is what is your diagnosis of this patient, and then we do recommendations. If sometimes other folks will document it as impression plan. So like, what's the plan for this patient? So in this case, I documented my impression, my final sentence, and I can read you my entire impression. It goes through all of my rationale behind how I came to my overall impression, my diagnosis of child physical abuse. And then I put my recommendations underneath that. And then when there's a thing called a charge navigator that pops up, and this is just how hospital EMRs work. When I go into that, like I finish my note, I sign it, then this charge navigator pops up, and then I have to put in there a diagnosis, so I sign a diagnosis. So for her, and it doesn't print on these, but like for her, I would have put child physical abuse, initial encounter confirmed, and then I would put...
If I could just interrupt, where does this appear in the medical record, that what you are referring to?
I have no idea where that would be in the medical record, but that would be how I guess if you pulled the billing sheet, you could see that. But I'm telling you, that's my diagnosis. And then I would also put in there a diagnosis for all of those rib fractures, for the other fractures, and assign a level, a billing level to it, and then hit submit. And so that's how it gets all put into the system.
Okay. Well, I think we're coming to the end. I'm going to try to wrap this up. But if I understand you correctly, your impression and recommendations from your consult note is your diagnosis in this case.
The impression, yes.
Okay. But it doesn't use the word diagnosis.
Right, it says impression, yes.
Okay, and so if a previous expert witness had testified that there was a difference between an impression and a diagnosis, would she just be incorrect?
Objection. That's a mischaracterization of the evidence.
I think you'd have to provide him with the testimony of the other doctor to put it in perspective. Not an open question like that.
Okay. Then let me ask it a different way. Is there a difference between an impression and a diagnosis?
Well, so your impression is, I guess it depends on the provider, really. What is your impression of that? What is your diagnosis? I would use them interchangeably. Suppose if you're saying, what is the diagnosis code, like what are you putting in as the, because we're limited by the ICD-10 codes, so you have to pick one that fits this situation. So that gives you the formal, like, diagnosis that goes into the, that's how they track things. especially the insurance companies. So that, but in my mind, they're interchangeable for my purposes of documentation.
Okay, so diagnosis and impression are interchangeable for you as a provider?
For me personally, yes.
Okay, I don't have any further questions at this time.
Oh, thank you. All right, she,
Mr. Honor, I've been told that there have been select members on the defense side that are actively making facial expressions and hand gestures while facing the jurors. So I would ask that they either stop or be asked to leave the courtroom.
I will, of course, ask anyone to stop who is making inappropriate gestures or faces as well.
all right, let me just ask this. I want to ask my bailiff and I want to ask court security to look at the audience, and if there's any issues, then we're going to basically address it through the contempt powers of this court, removal from the courtroom, or other proper sanction. No time should anyone be making any facial gesture and it's trying to intimidate or influence this jury in any way, for any reason. So, if it comes to my attention, the court will deal with it swiftly. All right? Anybody in the audience have any questions regarding that? Very well, thank you.
Thank you.
All right, let's bring our jury in, please.
I have a few follow-up questions for you. I'm still a little bit confused about your role at this hospital. Emma was in the care of an orthopedic doctor when she was in the ER, is that correct?
No, so she would have been, the treating physician in the emergency room would be one of the emergency room physicians. And so orthopedics would be a consult service, just like myself and my team.
Is it fair to say that Dr. Dana Azawoski didn't have any really concerns with non-accidental trauma? Her finding?
So she's the orthopedist. I can't state what her concerns were or not. Her role is to address primarily fractures. They do other address other issues with bones, but I mean they're the bone doctors, the orthopedists.
Based on the record, Dr. Dana Azawoski, Dr. O, basically prescribed vitamin D for Emma, right? So you're not polyvisal?
Yes.
Okay. And then they put a soft cast on Emma's leg, right?
Correct, this point. And then they may have been changed to a soft cast, yes.
Okay. Are you aware of any other recommendations or other course of treatment that the orthopedist recommended at CHOA for Emma at this point in time?
No, which I agree with. There wouldn't be, you can't, I mean, the rib fractures, you wouldn't cast rib fractures, and they were already healing. And the treatment for the corner fractures or the classic metaphyseal lesions is mainly comfort. So you don't need to cast those at all. The splint or soft cast was placed for comfort so that they wouldn't be bothersome to Emma. There's no other treatment that's really indicated.
Did Emma have any type of distress based on your evaluation of her?
Not when I examined her, no.
Were any parts of her limbs rendered useless in this particular instance?
So I would say that they were, when I examined her, that they were rendered useless. She regained full use of her legs. She didn't have any kind of injuries to her upper extremities. I would say when the injuries occurred, so there, and I mentioned this earlier, the fractures, that would be painful, and that she would experience pain at the time when the fractures occurred.
fair to say you didn't obtain any type of history from your father in this case, correct?
Oh, correct. Yes, I never had the opportunity to meet the father. He wasn't present at the hospital, and so he wasn't there for me to obtain a history from.
Would you agree, because of that, that the history, you would consider your history to be incomplete?
Say it's a little bit limited, just because we didn't have the father to provide like his family history, any history of trauma that he could provide. This has been, quite some time since I did my initial consult in June 6th of 2023. So we're coming up on almost 2 years. I've heard other histories, since then, that there is no trauma history. But, would it have been preferable if he were present at the hospital and I could obtain a history directly from him? Sure. But it doesn't preclude me from making my diagnosis based on the history that I had available to me.
What's the longest that you've ever gone in a case that you can recall as follow-up with a parent regarding a finding of non-accidental trauma? What would be the longest period of time that you could recall that you've gone in a case?
I don't understand the question. So the longest that I've gone,
You've been involved with
how long I've been involved? Like in this case, I've been involved until now. I'm still involved in this case. So
from
some
a
cases
diagnostic
could,
standpoint.
from a diagnostic standpoint. Personally, seeing patients in follow-up years out, those are, especially in cases of starvation, like a child being tortured and being like locked in a room in a cage, those sort of cases that I've had experience with. I've seen those patients longitudinally to make sure that I understand how they're doing. In a case like Emma's, it's typically I do my initial consult and then they will have their follow-up with another member of my team. Just like Emma, there's really no need for us to become more involved and have them come to the clinic unnecessarily for additional history obtaining, because it's all, we're getting different histories from the initial time when they're in the hospital, what's documented, and then if other things come up, like in this case, in Emma's case, I had a staffing on the 8th of June with DFCS and law enforcement and updated them on some of the labs that had resulted by that time, told them that my diagnosis was still the same, that nothing changed that. They were able to provide me with additional history, saying that there was no history of any trauma. So I do have follow-up. It just doesn't go on for, it's not like going to your pediatrician for a well child checkup and being seen at 2 months, 4 months, 6 months, 9 months, a year, 2 years. So
Go ahead, I'm sorry.
no, so it varies, but in cases similar to Emma's, it wouldn't be that I would see them. Maybe if I'm the one in clinic, then I see them in clinic, but it could be that I just saw them during the hospitalization.
But if I recall, you made your decision in this case on June 7th of 2023, correct?
My diagnosis, yes.
Your diagnosis. Would you agree it would have been a little bit more prudent to wait until all the results came in before making your diagnosis?
No, because as I stated earlier, these fracture types are highly specific for abuse. She was 2 months old. She had prior history of bruising to documented bruising, photo-documented bruising to her scalp, which I saw, historical bruising to her torso and her neck that the mom reported to me. If I were to not make the statement, not make the diagnosis at that time, it could be very dangerous for Emma to remain in that situation. Should anything come up, like in subsequent testing, additional history that would explain these things, I'd be more than happy to amend my diagnosis and update my diagnosis. However, knowing that the prevalence of child physical abuse far exceeds the prevalence of like osteogenesis imperfecta in society, it would be irresponsible of me to not make this diagnosis at the time when I saw her, because I'm a mandated reporter. I need to let the authorities who are responsible for keeping her safe know that everything that I have seen, that I have evaluated Emma for, all points to the diagnosis of non-accidental trauma. And I'm not some like zealot that like if something were to come up, you know, months down the road, say she had additional fractures or there was, you know, some other diagnosis, absolutely, I would not, you know, discount that. I would absolutely do what's right for the diagnosis for Emma. So I stand by this diagnosis. Nothing has changed in her diagnosis since my initial consult.
Have you ever amended or updated your diagnosis in the case?
Yeah, so I have had cases where it wasn't very clear initially, and then we get the follow-up skeletal survey, and then there's additional fractures that show up. Like I mentioned earlier about how we let the bones start to heal, and so we have a suspicion. The reason that my team gets involved is because somebody had a concern about this child. It's not like I am advertising on, you know, Facebook Marketplace or something. You know, come see Dr. Messner if you're concerned, you know, like if you want to be evaluated for child abuse. People have to refer these children to me or to my team. So there's an initial concern, and so I would expect medical providers who evaluate children, if they have a concern of child abuse or neglect, then they're going to ask for a consult from me. Sometimes there's kids, you know, we're just not sure. Like I mentioned the statistics earlier that we have from our team, about only 11% of the overall cases that we've reviewed over the past 3 years have we made a diagnosis of abuse in. So I've had kids who there's a concern, but we've, you know, myself or someone else on my team, we're like, this isn't, there's nothing that allows us to state that this is the diagnosis of abuse. So what we do is we bring them back, and then sometimes on occasion we will have additional injuries or additional findings that does make that diagnosis. So I have changed it in that direction. For our fellows in training, sometimes early on in their training they will make a statement, you know, wow, I feel like this is abuse. And then we have them go through the process, go through that differential diagnosis, go through everything about that patient, and oftentimes early on in their career, we will be able to show to them that it's not, we can't make that diagnosis because we know that making this diagnosis has a lot of implications, right? But we know that getting it wrong also has implications. So we do everything in our power to make sure that we get this diagnosis right. And we err on the side of caution, of underdiagnosing, as opposed to overdiagnosing.
There's a difference between diagnosis and mandatory reporting, though, right, Doctor?
There is, yeah. So the diagnosis is the medical diagnosis. I was making the statement about being a mandated reporter that we're obligated as mandated reporters to alert defects if there's even a concern of child abuse. And so, as a child abuse pediatrician, if I make that diagnosis, I want to make sure that everybody who is involved in protecting that child is aware of the diagnosis so that they can understand how these injuries occurred. I spend a lot of time educating them on the mechanisms of how the injuries occurred, and trust that they're going to do what's right to make sure that the child is in a safe environment.
Dr. Messner, you mentioned that there were no additional fractures, right, based on your knowledge?
Correct. We did find that one corner fracture down by the left ankle, which we, in retrospect, look back on the initial skeletal survey, was there. But since then, no more fractures. And so that wasn't really a new fracture. It was just a new finding on that follow-up skeletal. It was present on the first one. It was just overlooked because it was so subtle.
Well, at this point, Emma's already been loaded up on vitamin D, right?
I don't know what you'd say, define loaded up, but yeah, she was.
Vitamin D supplements.
Right? Yeah.
As prescribed by the orthopedic in the case, initially.
True. But like I mentioned earlier, her vitamin D level really had no impact on her bone health.
And your opinion for that is why? What's the basis for your opinion on vitamin D having no impact on her bone health?
So her body didn't respond to that low vitamin D. It takes some time for your body to start pulling the calcium out of the bones. So what's happening is it starts leaching the calcium out of the bones. The way it does, our bodies do that is we get a rise in the parathyroid hormone, which causes the calcium to be pulled out of the bones. So we didn't even have a rise in the parathyroid hormone. The calcium levels were already normal. There wasn't any other change to her, the salts in her body, so like the calcium, magnesium, and the phosphorus. And we didn't see any changes on the x-rays. So all of that in combination is how why I made that statement that the vitamin D really had, yes, it was low. We see that all the time. We see low vitamin Ds, low all the time. And kids who have fractures and don't have fractures. And there's the study which I mentioned earlier, which shows it doesn't cause you to necessarily have more fractures just because you have a low vitamin D. We see it at the same rate.
I heard you testify earlier that if it were vitamin D deficiency, that you would see problems with bones and other areas of the body. Is that what I heard you say?
Yeah, so what I was trying to convey was that it's a systemic thing, meaning it's impacting the entire body. You're not going to just get a change at the end of your femur, the end of your tibia. And where we look for it, we have the radiologist look at the ends of the wrists. So you'll see some like cupping. You'll see kind of like fraying of the ends of those bones.
Well, if it was a mineralization problem, it would show up in other places of the body. Is that my understanding? If it was a vitamin D deficient situation. What other places would it show up in the body? Do you have any research where it would show up first versus another place, or in the body, or in certain areas of the body?
No, I hope this clears it up. It's going to impact the entire body, right? Because you have low vitamin D. Where we look for the changes on X-ray, it becomes most evident at the wrist. So we look there and see like changes in the ribs. Even feel like a rachitic rosary, we call that. But you would not have what you see on Emma's X-rays. So knowing what we're seeing on Emma's X-rays, her lab values, I can state with medical certainty that she does not have rickets. That is not a factor here.
Did you look at her teeth to see if her teeth would be mineralized?
So she had no teeth when I saw her.
Okay. Fair enough. Do you have any information that her teeth have been discovered to be demineralized since your diagnosis?
No, I did see a report that she has hypoplastic central incisors, which is not uncommon. This means they're a little bit smaller. Not that there was any problem with the mineralization.
So you're saying that there was a finding of no demineralization in her teeth?
Not that I'm aware of, no. And your teeth develop differently than your bones do, so, no, I'm not aware of that.
As far as it's non-accidental injury with regard to the bones, did anybody mention any type of, or observing your team, and mention to you anything about bone bruising, or any indication of any type of bone bruising on the bones?
So that's not something that we would be able to detect. But bruising on the bone?
Yes, sir.
I mean, if you're saying like subperiosteal elevation because there's some bleeding, like when a bone breaks, you can see that on some of the x-rays, but it's not like your bones bruise like we see on the surface of your body. So I hope I'm answering that.
And to be
to
fair,
your
we're talking
satisfaction.
about healing fractures, right, in this case?
Both.
Already well healed?
No, so she has both recent acute fractures as well as healing fractures. So that's why we can say that this is on at least 2 different points in time.
What does an acute fracture mean?
So there's no evidence of healing on x-ray. Acute meaning recent. So that can be up to 7, 10, maybe 14 days, but generally it's in that 7 to 10 day range when we start to see radiographic signs of healing on x-ray. And that's why we wait that 2 to 3 weeks to get the follow-up skeletal survey, so then we can pick up on those signs of healing. We use that to our advantage to see if there was any subtle fracture that got overlooked on the first set of x-rays.
So you would agree that if a fracture is defined as acute, there is no signs of healing on that radiographic image, correct?
That's by definition, yes.
Let's get into the squeeze for a second here real quick. Messner. I heard you talk about a squeeze as being a mechanism of injury or something like this. Is that my understanding?
That can certainly cause the rib fractures, yes.
So you're not ruling out any other types of mechanism of injury, are you? You're just saying that's one potential mechanism of injury.
Correct.
You can get rib fractures from childbirth, though, correct?
Sure. As I stated earlier, we don't see them in isolation, though. The published reports see a clavicle fracture. It's rare to get rib fractures from birth, but they do occur.
Let's talk about sweat test for a minute. Is your understanding when it comes to the sweat chloride test that agents, they do have a lower mean sweat chloride value, correct? When it comes to the sweat chloride test?
That I don't know specifically, but I can tell you that Emma does not have cystic fibrosis, and that is the test that we use. That's the gold standard.
I heard you testify earlier that, and I appreciate you saying this, you can't say who did this, right?
Correct.
So you can't identify with any certainty in this case who caused these injuries, correct?
Right, and that's not my role.
I understand. But you just referred the case out to law enforcement basically and let them do their investigation.
Right, well, I don't refer it out. They get involved. Here in Georgia, all cases that are, that there's a defects report made on, it's supposed to also, like defects, lets law enforcement know. We will also, as a hospital system, if we have concerns, we'll sometimes make both a defects and a law enforcement referral. But that's done by our social workers at the hospital. I believe in this case it was Abby Rising, who's the social worker in the emergency room.
Now, it's fair to say you didn't do any follow-up with respect to Dr. Wilcox's findings in this case, correct? That you personally got involved in when it comes to the genetic situation?
Follow-up for the genetics consult?
Yes, sir.
No, I'm aware of Dr. Wilcox's consult and his impression or diagnosis, but there would be nothing else that would require me to get more involved in that.
You mentioned you've had contact with law enforcement in this case, right? You previously testified to that?
Correct. We did a staffing on the 8th of June.
Okay. Did you receive any additional information from law enforcement as to who may have caused these injuries with respect to Emma?
Not that I'm aware of. No.
Okay. In the example that you gave with regards to the squeeze situation, how many pounds of pressure would it take to cause such damage that you described as ceiling pressure?
So we can't do a study where we go around squeezing babies and find out how much force that would be. I can tell you, from attending autopsies of infants and handling their ribs, that it's difficult to break the rib. That they're pretty pliable, so they bend a lot. Even like our ribs, which don't have as much cartilage, you can push on them and they're not breaking. So, as I stated earlier, it would be a non-trivial force. It would be a force that would be harmful to the baby. It would break the ribs. It would be more force than I would expect anyone to use when handling a baby during normal interactions, like picking the baby up, burping the baby, changing clothes on the baby. This wouldn't be a force that you would just get from normal handling of the baby.
As an expert in this case, do you believe that Mrs. Hernandez, mom, did anything to hurt Emma?
It would be inappropriate for me to opine on who the perpetrator is in this. That is not my role by any means. That is the purpose of this trial. That is up to the jurors to decide.
Did you get any history regarding the mom from Asia, where she was born, or anything of that nature? Any medical records on mom from Thailand?
From Thailand? No.
Yes, sir. Well, I mean, your hospitals talk to each other, right? Even internationally.
Mm-hmm. So I didn't have access to mom's records. I mean, I have access to Emma's records through Care Everywhere. And I don't know if it would communicate with the hospital systems in Thailand. I spent a lot of time in Thailand. Actually, I brought medical students over there on numerous medical mission trips. And the medical record systems that I encountered when I was in Thailand were paper. They weren't on the computer. So I don't know how.
I guess my question is, did you make any attempt to get mom's history, whether it's on paper, digital, otherwise?
I have mom's OBGYN records. I know that, so I have those. I have Emma's pediatric records, but that's not the mom's. But I do have the mom's OBGYN records.
Have you ruled out every other possible explanation for these healing rib fractures and the lower leg bone fractures? Fair to say, you have not, correct?
I don't know if that's fair to say. I could sit here and testify to a reasonable degree of medical certainty that this is child abuse. And I believe that that is the threshold that I'm held to. I've testified over 200 times. I know what the legal requirement is. But to say that-
I don't think he's qualified as any kind of legal expert on any legal requirements here, and I would again renew my objection to this qualification in an area that includes the title of what is the province of the jury to determine.
All right, court's already ruled on the last issue. Doctor, we're not going to, you haven't, to my knowledge, but no legal opinions as far as what the law is.
And Your Honor, at this time, I do believe he has opened the door for the discussion of the medical attestation form and defects protocol.
I do not believe so. Overruled.
And Your Honor, the approach.
All right, ladies and gentlemen, I want to see you. All right, please be seated. All right, you may be heard.
Thank you, Your Honor. And I will say we did not receive a copy of the oral order from the court on Tuesday. So if there's...
It was filed. I'll make sure you receive it.
Well, and if I could have a copy of it, because I do believe that the witness has opened the door extensively by testifying regarding defect standards, his understanding of the legal weight and the legal issues in this case. I believe that, again, I will renew by...
Ms. Bernard, the court has addressed the purpose of that attestation with the defects. It is not relevant. He has not opened the door, so the court denies your request. I will honor your request to get you a copy of that order. And he is subject to cross-examination as to things that he relied on and everything else stated in my order. But we are not going into the defects form.
Even though he has testified,
Yes, ma'am.
he continues to be a part of Emma Hernandez's case, and that it is an ongoing case that he is still participating in as a treating doctor.
Yes, ma'am, because the attestation form is not relevant to any of the things that he's testified to. So the court is ruled. The court is ruled.
Continuing objection, and
Yes,
for
ma'am.
purposes of the record,
Yes,
I am
ma'am.
seeking to introduce the Department of Human Services memo regarding medically diagnosed child maltreatment assessments that states, as of February 14, 2025, that to strengthen the assessment of a medically diagnosed child maltreatment, specifically any medical determination that a child's injuries are non-accidental, this memo serves to establish level of practice enhancement.
Yes, ma'am.
And it requires that the Child Abuse Pediatrician sign a very simple attestation statement that merely includes patient information, physician information, and ask that the physician attest that he has thoroughly reviewed the medical history of the patient, including but not limited to past medical and surgical history, previous diagnoses and treatment, medication history and allergies, laboratory and imaging results, specialist and consultant reports, and hospitalization and procedure records. I confirm that I have considered this information in my medical decision-making and diagnosis for the patients. When I brought this up to Dr. Messner at the Dahlberg hearing, he became visibly agitated, so angry that he shook his finger at me through the Zoom video conference.
Ms. Bernard, you're wasting the court's time. The record is the record. I was there at the Dahlberg hearing. I understand. What he did during the Dahlberg hearing is not relevant to this proceeding now. Court has ruled on a motion in limine filed by the state. Court has issued a written order. Again, I will get that to you if you did not receive it, but we are not going into it.
And we understand your ruling, and I want to make a continuing objection for the record about our inability to be able to investigate the credibility, bias, and motivation of this witness as he makes the attestation that is the entire core of
Ma'am,
the state's
the only limitation I'm putting on is what I've written in my order, okay?
And Your Honor, we do not have a copy of that written order.
Well, how many more times do we have to go over that? I'll get you a copy, Ms. Bernard.
I would like it while Dr. Messner is on the stand, Your Honor.
All right, I'll get up and go get it myself.
Thank you, Your Honor.
Please be seated. Divide one each counsel.
We need two copies.
I want to give one to both defense counsel and one to Ms. Shue.
Thank you.
I just want to let the record reflect the court issued an order on state's motion to eliminate on May 13, 2025. It was filed here in open court at a hand stamp if it was not provided to counsel. I don't know why. I don't want to assess blame on anyone. In the normal course of business, when hand stamped, it is copies are provided. If they were not, then now you do have a copy. So the court stands by its previous ruling.
Thank you, Your Honor. And after seeing the written order from the state, we would make an oral motion for reconsideration regarding the court statement that the memo guides the actions of detached employees. And we would again cite to the memo itself, which has been entered previously into evidence during the Daubert hearing, that specifically guides the actions of the child abuse pediatricians who work at JOA, of whom Dr. Messner is one of the 5. So I want to make sure that that's on the record.
Your motion is denied. All right, let's bring our jury back in.
We're ready.
All right, please be seated.
Oh, Master, I just have one more question, and that is, have you ruled out medical, from a medical perspective, have you ruled out any other cause for this non-accidental trauma to Emma Hernandez?
Yes.
Every medical cause possible.
Yes.
Okay, no more questions.
No, regret my mistake.
Dr. Messner, do you get a commission for every child abuse diagnosis you make?
No.
Nothing further.
Anything else for this witness?
Yes, given the statistics that you testified to earlier, Dr. Messner, in how many of those cases, after a child has already been taken away from the family, have you gone back and revised your diagnosis of child abuse?
Which statistics are you referring to?
You referenced earlier that I think it's like 3,500 consults or 3,500 possible cases that then gets narrowed down to about 1,100 consults that you and your team do. And of those, you've only found 359 cases of child abuse, which is 35%. So in 35% of the cases that you consult on, you make a finding of child abuse, correct?
In 394 cases.
394, I'm sorry, I made it a little lower there. So, you mentioned earlier that if you did find subsequent information that called into question your diagnosis, you would happily go back and revise it. I'm asking you if that has ever occurred in your career.
Like I mentioned before, yes, there have been cases where there wasn't a diagnosis of abuse, and then with the follow-up skeletal survey or with additional injuries, we were able to make that diagnosis. So that has happened. That number is not 0. Have there been cases where I've called something abuse and then, or diagnosed it as abuse, and then down the road there was some other diagnosis that was discovered that would account for those injuries? No, I have not.
Okay. And how long have you been practicing?
Practicing? It'll be 21 years, yes.
Okay. And so there has never been an occasion when you have gone back to a previous diagnosis of non-accidental trauma and said, actually, more information has come to light. There have been new investigations into genetic variants and their consequences. I think we might have got it wrong on that non-accidental trauma. diagnosis?
That's correct. We're very conservative in making this diagnosis. So have I undercalled things? Absolutely. Have I overcalled things? No. If there was a circumstance like that, I would freely change my diagnosis. I would state that. I have no qualms about that. I just haven't, my practice is not to, it's to look at everything in totality, look at the information that's available at that point in time. And if I can make a diagnosis, I do. If I can't, then I will wait until we get additional tests. In Emma's case, I was able to make that diagnosis then, based on everything that I explained to you guys. Because of that type of practice, I haven't had a case where something has come up later that would then explain the injuries that caused me to come up with that diagnosis at that point in time to change it. Now, could that happen, in the future, potentially? It's not the case for Emma. I've reviewed everything. There's not anything else to explain these injuries. That's my answer to that question.
Okay, and in terms of the under 2 hours that you spent on Emma's case total before making this diagnosis, is that fairly standard in these cases, or do you usually spend longer or a shorter amount of time investigating before making the diagnosis?
So having that statement of under 2 hours to make the diagnosis, I was reviewing the medical record the time I became aware of Emma's case. So I can't tell you exactly how many hours it was. I did document 115 minutes. Yes, that is under 2 hours. I've been reviewing everything prior to that. Now there's going to be variability in whether I can make a diagnosis in a shorter period of time if I have that information available. Like in Emma's case, the CT scan was already done. The skeletal survey was already done. I had the lab work that I needed at that time back. I had the history from the mom. So yes, I was able to make that diagnosis in a relatively short period of time. Could it be quicker? Yes. Sometimes does it take longer? Yes. So it is very variable. But if I make the diagnosis, it's based off of the totality of everything that I have available to me in that case at that point in time.
And have you signed off on any orders in Emma Hernandez's medical records for her care and treatment?
Yes, I ordered the osteogenesis imperfecta testing.
That's the only one?
Yeah, because like I mentioned, we have this non-accidental trauma pathway. So the initial physician who sees the patient, if that comes up as a best practice alert, they consider it. They are the ones who order. And in the emergency room is where the majority of her tests were done. And in our hospital system, the only providers who are allowed to order in the emergency room are the emergency room providers. So that is the emergency room physicians and the APPs in the emergency room. But all of that had already been ordered and completed by the time I had the opportunity to complete my consult the following day.
And you were not involved in any of and you ordered the OI after you'd already made your diagnosis, right? You ordered the OI panel after you'd already made your diagnosis?
It may have been at the same time. I can't tell you that, but the results came back after the diagnosis, yes.
Okay. I believe those are all my questions. Thank you, Dr.
All right, thank you.
Just two more questions, because a lot came up during the talks. So you talked about the labs, right? And you reviewed those labs?
I did what was available, yes.
I noticed in the medical records, you can correct me if I'm wrong, but you correct me if I'm wrong, but you say that the labs are reassuring in several places in the medical records, correct?
That's not in any of my documentation.
That's not, you never said that in any, never?
Not in my notes, no.
No, okay. Did you ever tell another doctor that her lab results were within normal limits? In any of your documentation?
I mean, she does have labs that are within normal limits. Would I have had a conversation with the provider and state that? No, I can't see a scenario where that would come up. We all have access to the records. You know, pull it up on the computer, you can pull it up on your phone. We can see what the lab results are. So I can't recall ever having that conversation, and that would really be atypical for me.
Do you believe that her labs were within normal limits?
Well, she has a few lab values, which I mentioned earlier, like her vitamin D was below normal of 20. Her D-dimer was elevated, and her fibrinogen was slightly elevated. So technically those are abnormal because they're outside of that normal range. So AB meaning not normal, abnormal. So I wouldn't say that they're all within normal limits.
Okay. That's all I have.
All right, very well. Anything else?
The subsequent OI results change your diagnosis at all?
No.
All right, any reason why this witness can't be released?
No, Your Honor.
I mean, Your Honor, we would ask that he remain subject to recall, given that the state does intend to call additional witnesses from the
He can be released from my subpoena, Your Honor.
I don't know if he's under subpoena or otherwise. I will ask you just to honor your subpoena, Doctor.
I will.
All right, thank you. You are excused. All right, anything else that we can address, Ms. Yee?
Your Honor, the state did file a motion in limine based off of defense's opening on their therapist or psychologist
Please be seated.
testifying as to their opinions on the parental fitness of the defendant. So the state is asking that be that their testimony be limited to prohibit that information as it is improper character evidence.
I don't know if are we ready to take that up right now, or?
I'm happy to take it up right now. You did receive a copy of the motion,
Okay.
Your Honor.
I've not seen it, so that's why I'm asking.
Oh, well, I don't know. We're at the court's pleasure.
No, I'll hear from you. I'll see if I can't follow along.
Well, and Your Honor, of course, it is only our intention to introduce appropriate and relevant evidence. We do have a number of folks on our witness list who are the CASA workers, the transporters, the counselors, the people to whom my client and his wife were forced into participation with in order to maintain any amount of contact and visitation with their children throughout the past 2 years of the DFACS process. And so these are all individuals who have observed my client, his interactions with his children, have observed the children. So they will be fact witnesses, and I do believe that the question of parental fitness is relevant to this determination because the ultimate issue of the case is whether or not they committed these horrific acts of abuse alleged against them. And so we do believe that it would be appropriate for us to go into evidence from, again, individuals who are employed by or contracted with DFACS for the purpose of ascertaining parental fitness. The fact that my client and his wife passed all of these tests with flying colors, we believe is highly relevant to the jury's determination of whether or not they are likely to have abused their children.
Well, fact witnesses are one thing, giving opinion is another. So I don't know what they will be addressing.
Well, Your Honor, we may tender, I mean, that's another thing too, we may qualify them as an expert witness based on their education, training, and experience.
Well,
We'll have to take it one witness at a time as far as that, just like the state.
but we don't go into character though.
Well, experts, I mean, Also treating physicians too, and you know, some get into how
Well,
they.
treating physicians not giving opinion as to, like, if they're a good parent, by example, or that someone is act appropriately around children.
Well, when it comes to like a
So,
psychological profile, I mean, I think that's relevant evidence in the case like this.
Well, why don't we do this? Why don't you provide me some authority for all this?
Yes,
okay?
ma'am.
Certainly not.
And that way we're just not discussing it in general. If you have some authority, let me know what it is.
Thank you.
But let me just, so we've got various individuals who have interacted with the defendants, in addition to factual recitation of what are they going to testify to, just in general, just so I have an idea. What opinions are they going to be making?
I just don't know who the state is referring to in terms of particular individuals.
Is it in your motion? Is it something?
Your Honor, I don't know who they intend on calling for that purpose. They mentioned it in the opening that they intend on calling counselors, therapists, or psychologists that were going to testify about defendant's parental fitness and the children's desire to be reunited with the defendants. And so the state's moving to prohibit such testimony because,
Okay.
one, it's parental fitness is character evidence, but then also the children's desire to go back to the parents, that would also be hearsay, and it doesn't fall under the child hearsay rule.
Okay. So we've got someone who would give opinion about parental fitness, and we've got testimony from 2 children that would be hearsay. I don't know if I need a brief on that, but anyone else? I mean, I hear there's going to be people that are fact witness. Are they going to give opinions about?
I'd like to look at the motion, Judge, and then look at the witness list and kind of respond that way. I think it's timely, you know, to take a good look at
Okay.
it.
All right, well, everybody look at it. We'll address it tomorrow as may be appropriate, okay?
Thank you, Judge.
Thank you very much.
All right, thank you. All right, we're in recess 8:30 tomorrow morning.